Welcome to the deep dive. Today we're taking on something pretty ambitious, a really high-stakes mission actually.
Hmm.
We are plunging into a comprehensive medical text that's focused entirely on the applied anatomy of the head, neck, face, and brain.
That's right. And the source material here, it's basically a masterclass in surgical anatomy. It is dense, it's very clinical,
Right.
and, it all operates under this one principle that really understanding these anatomical relationships is, well, it's the single biggest predictor of a successful clinical intervention.
So our goal is to pull out that foundational knowledge.
Exactly. The life-saving details that every medical student and, young professional really has to have mastered.
Cold. We aren't just reading off a list of structures. We're going to be tracing the pathways of trauma, the spread of infection, and really the precise margins of error that can make or break a diagnosis or a surgery.
As the author puts it, we're trying to uncover that hidden surgical and clinical thrill of practical importance.
So where do we even begin? Let's start at the very top.
Okay, so we begin with the view presented in the text, which is that anatomy isn't just descriptive science. It is the absolute bedrock for every clinical science that came after it.
The foundation.
The foundation.
Yeah.
Without mastering this stuff, the progress we've seen, organ transplants, complex neurosurgery, all the non-invasive techniques, it just wouldn't be possible.
Okay, so if anatomy is the map, let's look at some key landmarks on the skull itself. When we look down on the top of the skull, what anatomists call the norma verticalis, there are two meeting points that are just vital. The first one is bregma.
Right. Bregma is the intersection where the coronal suture, which runs, side to side, meets the sagittal suture running front to back.
And in a baby.
In an infant, this is the spot. It marks the location of the diamond-shaped anterior fontanelle.
Okay, and the second point.
That would be lambda, which is more posterior. It's where the sagittal suture meets the two lambdoidal sutures. And at birth, this corresponds to the triangular posterior fontanelle.
And help us understand why these soft spots, these fontanelles, are so critical beyond just, development.
Well, they have two really critical jobs. During childbirth, they let the skull bones overlap, which reduces the head size for passage through the birth canal.
Right.
And then afterward, they accommodate that just explosive brain growth that happens in early childhood. But their clinical use, that doesn't stop when they close up.
And here's the part from the source that I just found fascinating. This anterior fontanelle, which closes around 18 months or so, is, well, it's like a dynamic diagnostic window.
It's exactly that. A window, its tension tells you so much.
Like dehydration.
Precisely. If you feel it and it's palpably depressed, you're immediately thinking dehydration. On the other hand, if it's tense and bulging, even when the child is calm and upright, you have to consider really serious things.
Like meningitis?
Meningitis, hydrocephalus. But it goes even further. Lying directly underneath that fontanelle is the massive superior sagittal sinus.
So you can access it.
In a crisis, yes. That fontanelle offers therapeutic access, a direct window for drawing blood, for delivering infusions, or giving emergency meds right into the circulation. It is a keyhole into the cranium.
That makes the bone structure so much more functional than just a box.
Okay, let's switch gears a bit. Let's talk developmental anatomy, specifically the pharyngeal pouch derivatives.
We have to highlight the first pharyngeal pouch. This one pouch is responsible for developing basically the entire auditory apparatus. So the pharyngotympanic tube, the middle ear cavity, the tympanic antrum, and crucially, the mastoid air cells.
Which brings us to the mastoid process.
It does.
No.
And this gives us a perfect example of why pediatric anatomy is not the same as adult anatomy. Not even close.
How so?
That mastoid process, that bony lump you can feel behind your ear, it's completely absent at birth.
Really?
Completely. It only develops over the first couple of years, with the bony structure really forming in the second year. And what's critical about its absence is that it leaves the facial nerve, CN7, totally unprotected as it exits the skull. So if the facial nerve is superficial in an infant, what's the immediate clinical danger there?
Any surgeon operating in that region on an infant has to be acutely aware of this. A simple mastoid incision, if it's misplaced by just a little, could easily sever that nerve.
Leading to permanent facial paralysis.
Exactly. And to add to that, the air cells inside the mastoid, the ones that get infected in mastoiditis, they don't fully appear until much later, maybe around age 6. This all just dramatically changes how you approach procedures in this area, depending on the patient's age.
All right, let's move down from the head into the neck. This area is, well, it's a complex series of layered compartments. And these fascial layers, the connective tissue, they are everything when it comes to the spread of infection.
That is the essential lesson of the neck. If you don't understand the planes, you can't predict where an abscess will go.
So which layers are most important?
We're mainly concerned with the deep cervical fascia. You have the investing layers, like a collar really, splitting to enclose the big muscles like the trapezius and sternomastoid. And deep to that, you have the tough prevertebral layer. It lies right in front of the vertebral column, covering muscles like the longus colli and the scalenus group.
I found the pathway that prevertebral layer creates particularly alarming. If an infection gets behind those muscles, where is the express route out of the neck?
That layer continues laterally and it forms the axillary sheath.
Mm.
This structure surrounds the brachial plexus and axillary artery. So an infection, like pus or blood, in that deep prevertebral space has a direct, unimpeded path straight down into the axilla,
The armpit.
the armpit. A surgeon tracking a deep neck infection must always, always check the axilla.
Now, inside all of that, you have the really critical infrastructure, the carotid sheath. This isn't a layer itself, right? It's more of a special container.
It's a special condensation of fascia, yes.
Yeah.
And it contains the next critical structures.
Yeah.
Comma carotid artery, the internal jugular vein, or IJV, and then tucked in posteriorly, the vagus nerve.
You know, regarding the IJV, there's a key asymmetry to remember, isn't there? Especially for placing a central line.
A huge one. The right IJV is aligned almost perfectly with the right atrium of the heart. That makes it the preferred and much safer route for central venous access. The left IJV, on the other hand, it has a longer, more winding path, and importantly, it anatomically overlaps the left common carotid artery.
Wait, why does that slight overlap matter so much to a practitioner placing a line?
Because if that left IJV is a bit smaller, or if your needle insertion isn't absolutely perfect, that overlap dramatically increases the risk of you accidentally puncturing the left common carotid artery. It's a classic anatomical trap.
Wow. Okay. Now, the action really heats up in what's called the carotid triangle. This is where the common carotid artery splits.
It does, right at the upper border of the thyroid cartilage. It bifurcates into the internal and external branches. And this is also the location of that famous hat trick of the hypoglossal nerve, which is cranial nerve 12.
A hatch.
Yes. This nerve, which controls most of the tongue's movement, has this very unique visible course. It crosses three major arteries in a row. First, the internal carotid, then the external carotid, and finally, it loops over the lingual artery.
And why does the source highlight that path as so critical? It sounds like a useful landmark.
It is indispensable. If a surgeon needs to ligate the lingual artery, say, to control bleeding during a tumor resection, that hypoglossal nerve is the perfect guide.
So you follow the nerve to find the artery.
You follow the nerve. If you see it crossing, you know exactly where that artery is, and more importantly, how to avoid damaging the nerve itself. And we also find the sensory bodies here, the carotid body, which has chemoreceptors, and the carotid sinus, with its baroreceptors for blood pressure.
Okay, bringing us back to infection pathways. We mentioned abscesses tracking through fascial planes. Let's talk about the peripharyngeal space.
This is a classic potential space.
Mm-hmm.
It's shaped like a cone, running from the base of the skull down to the hyoid bone, and it's a critical site for deep abscesses, often after something like a tonsillectomy.
And swelling here can look like quinsy, right? A peritonsillar abscess.
It can look like it, but there are key differentiators.
Okay.
Quinsy is an abscess right next to the tonsil.
Okay.
And while both cause terrible throat pain, the source notes that a peripharyngeal abscess often comes with two additional critical signs: swelling over the lower parotid area and, most tellingly, trismus.
Trismus being lockjaw.
That painful involuntary spasm of the jaw muscles. And that's typically absent in simple quinsy. The presence of trismus forces a surgeon to look deeper into that peripharyngeal space.
Right, let's move up into the skull base, into these really intricate anatomical boxes, specifically the infratemporal fossa.
You know, what's interesting about this space is what anatomists always emphasize it lacks. It has no floor and no posterior wall. Its roof is formed by the sphenoid bone.
And while this space has a lot going on, there is one structure passing through its roof that demands immediate surgical attention.
That is the middle meningeal artery, the MMA. It's a branch of the maxillary artery, and it enters the middle cranial fossa through the foramen spinosum. Once inside, it runs these grooves along the inner surface of the skull bones, particularly close to a very weak point on the side of the skull called the pterion.
And this proximity is the setup for one of the most famous clinical thrills in all of neurosurgery.
Indeed, a forceful blow to the side of the head, even one that doesn't cause a skull fracture,
Right.
can tear the MMA near the pterion. And because this is an artery, the bleeding is high pressure. It's fast. It leads to a rapid collection of blood between the dura mater and the skull.
An extradural hematoma.
An extradural hematoma. This mass just quickly compresses the motor cortex right underneath it, causing a rapidly developing contralateral paralysis. The need for immediate intervention, for trephining, drilling a hole to relieve that pressure, is an absolute life-or-death race.
From the vault down to the face. Let's talk about the notorious danger area. This involves the upper lip and the sides of the nose. I think many people will be shocked to know how dangerous a simple pimple there can be.
The danger comes from the venous anatomy. The anterior facial vein, which drains this whole region, is unique. It doesn't have any valves.
Meaning the blood can flow backward?
Exactly. Unlike veins elsewhere, blood can flow retrograde from the face toward the cranium.
And what's the direct connection to the brain?
Well, that anterior facial vein connects to a major intracranial venous channel, the cavernous sinus, through two routes: the deep facial vein and the inferior ophthalmic vein, so an infection in that danger area.
From, say, squeezing a pimple.
Exactly. Staph from a nose furuncle can travel directly along that pathway against gravity and cause cavernous sinus thrombosis. This is a potentially fatal condition.
That really reinforces how interconnected everything is. Before we move deeper into the skull, let's touch on the salivary glands. Some high-yield facts here.
Okay. The submandibular gland, it produces a thick, viscous secretion, and its duct drains non-dependently, meaning it has to flow slightly uphill to exit.
So thick, fluid, uphill battle.
Right. And that combination results in a much higher incidence of salivary calculi, or stones, in the submandibular gland. The parotid gland, on the other hand, produces thin, serious saliva, so it gets fewer stones.
And parotid surgery has a very specific and kind of strange nerve complication, Fraze syndrome.
It is strange. And it's a great example of nerve misdirection. During parotid surgery, the auriculotemporal nerve can be damaged. When it regenerates, those fibers, which should go to the parotid gland, get confused. They mistakenly connect to the sweat glands in the skin over the top.
So what happens?
So when the patient sees or smells food, a gustatory stimulus, they sweat profusely on their cheek instead of producing saliva. Gustatory sweating.
Wow. Okay, now let's go into the cranial cavity itself. The dura mater, the tough outer covering of the brain, is critical here.
It is. It does more than just protect the brain. Its inner layer forms these really strong partitions, like the falx cerebri between the hemispheres and the tentorium cerebelli, separating the cerebrum from the cerebellum. They're essential for stabilizing the brain.
And these structures help us distinguish between the different types of hematomas we've talked about, don't they? A chronic subdural hematoma has a very different cause than the rapid extradural one from the MMA.
Absolutely. The chronic subdural usually comes from a low-pressure rupture of the bridging veins. These are tiny veins that bridge the gap between the brain's surface and the big dural sinuses.
And they tear easily.
They do. They can be torn by a sudden displacement of the brain. Even a minor blow, a really hard sneeze, or a cough in an elderly patient. And because it's venous blood, the accumulation is slow. It can take weeks or even months for symptoms to show up.
Let's focus on those dural venous channels again, specifically the cavernous sinus. It's located on the side of the sphenoid body, and its contents are extremely unique.
What makes the cavernous sinus so fascinating and so clinically dangerous is that the internal carotid artery, a major high-pressure vessel, passes directly through it. It's traversing a venous space. This intimate relationship is almost unique in the entire body.
So what happens when that relationship breaks down?
If you have an injury or a defect that causes a connection between that high-pressure artery and the low-pressure sinus, an arteriovenous fistula, the arterial pulsations get transmitted right into the venous system.
And clinically, that shows up as
A very dramatic sign, a pulsating eyeball. The eye becomes congested, it bulges forward, proptosis, and you could literally see the globe pulsing with the patient's heartbeat, all due to that high-pressure influx.
incredible. Finally, let's discuss the pituitary gland, or hypophysis cerebri, sitting in the sella turcica. This tiny little neuroendocrine center punches way above its weight when it comes to critical anatomical relations.
Its immediate neighbors are everything for a surgeon. Anteriorly, it's right up against the optic chiasma, the point where the optic nerves cross. Laterally, it's next to the cavernous sinuses. So a pituitary tumor, when it grows superiorly, presses on the optic chiasma.
And that pressure causes a very classic, very specific visual defect that is almost diagnostic for the tumor's location.
Correct. It typically compresses the crossing fibers from the inner or nasal retina of both eyes. This leads to a loss of the peripheral visual field on both sides.
Which is known as bitemporal hemianopia.
by temporal hemianopia. And to treat tumors located below that, surgeons often use these minimally invasive routes, like the transphenoidal or transethmoidal approaches, to avoid all the sensitive structures above and to the side of the gland.
We have tracked so much crucial clinical information across all these regions, really connecting the dots from surface landmarks to the deep structures that govern outcomes. It's so clear that anatomy isn't about memorization. It's about predicting the trajectory of disease or trauma.
Indeed, the critical details we talked about, the direction of blood flow on the face, the path of a deep neck infection, the location of a nerve in relation to an artery, all of that dictates the safety margins in surgery.
Right.
So to really test how well these concepts synthesize, I have a comprehensive challenge for you, for the learner, that integrates the neck and the larynx.
Okay, let's hear it.
We discussed the carotid triangle earlier. Now, inside that space, I want you to describe the nerve supply of the only intrinsic muscle of the larynx that's actually located outside the main laryngeal structure. Explain its unique role in voice production, and then connect that to the caution a surgeon must take when ligating the inferior thyroid artery near the thyroid gland.
That's a perfect test of applied anatomy. All right, let's break it down. The muscle we're talking about, the one located externally, is the cricothyroid muscle.
Correct.
Its nerve supply comes from the external laryngeal nerve, which is a branch of the superior laryngeal nerve, which comes from the vagus cranial nerve X.
And its function, what does it do?
It is the only tensor of the vocal cords. It stretches them. And this is crucial for producing high-pitched sounds. If this muscle is paralyzed, your voice becomes monotone, flat.
Exactly. So, given that vital function, what is the life-saving caution during that arterial ligation?
The caution involves the other major nerve of the larynx, the recurrent laryngeal nerve. This nerve supplies every other intrinsic muscle of the larynx, and it runs in extremely close proximity to the inferior thyroid artery right near the gland.
So they're right on top of each other.
Practically. If a surgeon damages that recurrent laryngeal nerve while ligating the artery, the patient will suffer severe hoarseness, maybe even lose their voice. The anatomical closeness of that artery and that nerve means surgical success requires millimeter precision to protect vocal function.
A textbook example of how a vascular procedure immediately impacts neurological function.
Absolutely. Thank you for guiding us through this challenging but just critical anatomical survey. To the listener, take this information, continue to connect these dots between structure and clinical application, and you will find that applied anatomy is truly the most thrilling geography of all.